I'll just talk loudly for the introduction. That's usually how we do it because you're all mic'd up.
I'm all mic'd up.
You're all mic'd up.
Yeah.
Good afternoon, everyone. Welcome to Pediatric Grand Rounds. As the last few people get their lunches, I just thought I would start with a few housekeeping items. As several of you know, I'm Dr. Jay Shankar. I'm one of the general pediatricians with ETSU Pediatrics. For our Grand Round CME, we have a new system. As you may know, we would like you to sign in at the back desk with Donna and Marta, who will help you through the process if this is the first time that you're doing it since we went to the new system. There is a QR code scanner back there. You do have to sign in to their Highmark system online to be able to get credit. And you have to go back within 48 hours and put in your evaluations. 72 hours. I apologize. 72 hours. Put in evaluations and claim credit, otherwise that credit disappears. So please, please, please pay attention to this new process. Again, as lots of you know from the past, this is how we also look at our attendance for Grand Rounds and continue with accreditation for Grand Rounds. So even if you're a medical student or resident who doesn't currently need CME, we really appreciate you going through the system and claiming credit so that we know how many people are here at Grand Rounds. With those few housekeeping items, it's my privilege and pleasure to welcome Dr. Jeanann Pardue from East Tennessee Children's Hospital here with us today. Dr. Pardue, as she told me, is a native Tennessean, really is from our part, started her undergraduate at Vanderbilt, and then, like she said, went away to Texas for a few years, did her pediatric residency at Baylor before coming back to East Tennessee. She's been with East Tennessee children for going on
28 years.
28 years now, wow. And is the chief quality officer there. She is a hospitalist and her passion is in QI. And so she's really truly our expert here today to help us with understanding more about the art and science of diagnosis as well as patient safety and quality. As we all know, this has become more and more the forefront of what we do and a very important topic. Dr. Pardue's CV reads several pages, so I'm not going to go into all of those details, but just to share with you that she has focused a lot of her efforts in the initiation of a care map and practice guidelines for the management of asthma and address the transitions of care and engage community providers with that QI improvement effort. She was invited at the state level to be a member of the technical advisory group that we're all aware as general pediatricians and in the outpatient setting around the management of an acute asthma exacerbation. She is also the co-lead of the Children's Hospital Alliance of Tennessee Quality Collaborative to improve care for patients with asthma. She has also been on various AAP committees and has helped develop guidelines that we use today. So I'm very excited to have Dr. Pardue here with us. Thank you.
Did everybody start to get a little bit uncomfortable? We're wondering what was I doing if I forgot what I was going to say? That moment of silence, I think it really makes us all feel ill at ease. So what if you had an 8-year-old child that was newly diagnosed with acute lymphoblastic leukemia, who was admitted to the hospital for their induction therapy? What if they were scared? What if the resident that saw that patient diagnosed the patient with anxiety? What if about a week later, the little girl started to feel weird? The patient, she was immunocompromised. She had some vital sign changes. The team called the resident on call, and the resident reviewed the history and physical, saw the diagnosis of anxiety, and treated the patient with Ativan. What if, over the next 12 hours, she continued to become more anxious, more lethargic? The mom is continuing to express her concerns about what is going on with her child. And finally, she reaches down and feels the hands and feet, and they're cold, and she screams, "Do something now for my child." Finally, the team arrives, they diagnose sepsis, transfer her to the ICU, begin treatment, but it's too late. And all the mother heard was silence. Silence when she was expressing her concerns. Oops. And silence from her daughter, and silence when she wanted to know why. Why did this happen to her daughter? Have you ever noticed that silent and listen have the same letters in them? When what that mother really needed, what her child really needed, was for us to listen. To listen to her when they were treating her for anxiety, when she said, "My child is not anxious. She's just scared. She's an 8-year-old that's just been told she has cancer. Her dad just finished chemotherapy for cancer, so she knows what's going to happen, and she's scared." She wasn't anxious. When she wanted somebody to listen to her and tell her why. Why did this happen to her daughter? This is a true story. This is Alyssa's story. I first heard Alyssa's story about 4 years ago at a National Patient Safety Conference. Carol Hemegard has become a parent advocate for diagnostic safety, for really trying to get the message out and improve the way we think. I had her come to our hospital about 2 years ago to share her story and really to kind of kickstart us along our journey. So this is the obligatory disclosure sign, and I have nothing to disclose. So we'll kind of move on. I have been practicing medicine for 32 years. Have you ever wondered why we call it practicing medicine? It's because we never really perfect it. It is a day-to-day journey of continual learning and can't move there, I don't think, continual improvement. We all have our own stories, and if you practice long enough, you'll have many stories of your misdiagnosis. For me, the stories that haunt me is the missed appendicitis, the delayed recognition of congestive heart failure in the middle of bronchiolitis season when we've had the diagnosis of bronchiolitis on a patient. We all have our stories, and those stories should continue to propel you to want to learn more and do better. This book, Every Patient Tells a Story, is full of stories, but what it focuses on is the art of diagnosis. And it is an art. For every patient that presents to you with a need for a diagnosis, they want you, they demand you to master that craft of making a diagnosis. And it is a craft, and it's a craft that we need to own. So this is what we're going to do over the next little bit. These are the high-level objectives, and I'm just going to give you a broad brush on diagnostic safety. We're going to talk about the why. Why is this a concern? The what is the diagnostic process? The how do we make mistakes in it? And then what do we do now? How do we get better? So before we start, I'm going to give you some homework, which is really my list of references that I've kind of used for as we've continued our journey. The Institute of Medicine in 1999 really gave us the Sentinel article that really propelled us on our patient safety journey, To Err is Human. In 2015, they published this book, Improving Can you see the title? Improving Diagnosis in Healthcare. And this is really the same thing, but focusing on how we need to get better in the process of diagnosis. The next book was published in 2017, just last year, and it's really talking about measurement of diagnostic safety. Diagnosis, Interpreting the Shadows is written by 3 of the leading thought leaders in diagnostic safety, and it was just published this last year. If you want a good general overview, for any resource that you want to truly think about what we can use in your hospital, this website on improved diagnosis in medicine. And then a really brief article was published this past summer in the Journal of Pediatrics that gives a high-level overview of diagnostic safety. Can everybody hear me over there? Okay. Sometimes I hear an echo. So this is your homework if you want to learn more. So if you're going to study something, you have to define it. So the Institute of Medicine, which is now called the National Academies of Engineering, Medicine, and Science, and I'm not going to use that name because it's too long, defined diagnostic error is the failure to establish an accurate and timely explanation of a patient's health problem or communicate that explanation to the patient. It's either missed, delayed, or wrong. How prevalent is that? So they look back at a lot of outpatient records, at a lot of inpatient records when we look at patient safety, and a lot of autopsy results. And the range is anywhere from 5 to 17% of all patients that present to us experience a diagnostic error. And I think we would all recognize that diagnostic error is the leading cause for paid medical malpractice claims. So what is the diagnostic process? The Institution of Medicine really put this schematic together that outlines all the steps that we go through when we make a diagnosis. The patient presents to us. We then go through that process of information gathering and integration, and that process can be a continual wheel. And then we make a diagnosis, we communicate it to the family, we implement treatment, and then we hope for a good outcome. If we don't get the outcome we expect, we may have to go back to that wheel on that circle and continue on. But it's a complex process. And one of the main reasons that it's complex is because of the thousands of the diseases that we could diagnose. The body responds to illness and injury in really one of 5 ways. So they all potentially have similar characteristics of presentation. This was described in 1st century AD, and it really hasn't changed that much. But the linchpin of our diagnostic process is the art of medicine. It is our history and physical exam. And there's been a lot of literature published in the last 5 or so years that we are losing that art, that we're not performing, especially with the physical exam, that we are losing the ability to perform a meaningful physical exam and to glean the information that we need from that physical exam. We all know who Dr. House is, the master diagnostician on television, and he would say that all patients lie. So he sounds like he's dismissing the history. But even in saying that, if you look at the patients that have come up with those weird diagnoses they do on TV, 90% of the time, the key clue comes from the history or physical exam, not the myriad of battery of tests that they order to make that diagnosis. Recent literature also suggests, kind of validates that, what they're showing on TV. There's not much that you can validate about Dr. House, but it does validate that 60 to 70% of the time, your diagnosis comes from your history. Then the next 25% of the time comes from your physical exam, and the physical exam, more often than not, leads you to more focused testing. So it's an art that we really do need to perfect. And I think there's some changes in the way medical education from my day of being educated on really how important this history and physical exam is. So how can we fail? Patients sometimes don't present in a timely manner. That's the first opportunity for failure. We don't do a good job of gathering the information that we need to gather. We don't interpret correctly. We don't establish a diagnosis, and I think one important thing we don't think about a lot is we don't communicate it well to the family, so they don't understand what they have and what they need to do about it and what they need to be looking for. It fails because diagnosis is hard. It's an imperfect science. Our biologic systems are complex. Diseases do not read the textbooks that we write. So I think those classic symptoms that we say that you're going to have when a patient presents don't happen all the time. When they do, it's great. Most of the time, it's very complex. I think we have a hard time saying, I don't know what's wrong with you. So we tend to make a presumptive diagnosis, and that kind of leads us down a path of no return sometimes, when we really need to say, I don't know, and it gives you a bigger opportunity to continue to gather information and move forward. And we have to recognize there is a diagnostic trajectory. A 2-year-old that presents with, on the second day of fever, I'm not going to be able to make the diagnosis of Kawasaki's disease. But if I think it's a possibility, then I need to communicate that and follow that diagnostic trajectory as that patient moves forward. So in patient safety, we like to think that the system is the big problem, that as a human, we are functioning in a very complex system, and we need a system that's going to support us to function well. In diagnostic safety, it really is us that's the biggest problem. There is not a lot that the system can do to support this process. So we really have to own this improvement for us as an individual. And it's not what we know. We know a lot. We know enough. It's how we think about what we know is the big problem. And we'll talk about this more, but we really have two kinds of thinking, intuitive and rational, and most of the time, we are victims of our own critical thinking. The master diagnostician, Sherlock Holmes, put it this way when Watson asked him, really, how did you figure that out? I didn't see, sorry, I can't come over that way anymore. I'm sorry, over there. I'll wave at you. He thought the clue was invisible to him. And what Holmes said, no, it wasn't invisible. You just didn't notice it because you didn't know where to look and you didn't know what was important. So I think that's really kind of sums up that the diagnostician. And if you don't know, Sherlock Holmes was actually modeled after a surgeon that was a friend of that the author had worked with. So how do we think? This book is really, when you think about cognitive science, the science of thought, this is a Sentinel book on thinking fast and thinking slow, and it really describes our critical thinking process as well. We all, as humans, have a capacity for rationality, and that is really based on the knowledge we have, our inherent capabilities, and then what are our individual characteristics at the time. Think of road rage. The smartest person can be irrational sometimes, depending on if they're stressed, if they're sleep deprived, if they're hungry, if they're having a bad day, in a bad mood, impaired. All these things can hamper our capacity for rationality. And then it's the way we think, our critical thinking skills. So how do we think? Our brain works in two modes. System 1, which is our fast brain, System 2, which is our slow brain. In our fast brain mode, these are things that we do automatic. Brushing your teeth, putting on your clothes. You don't think about the steps along the way. Tying your shoe, you just do it. Over 90% of the time, we function in System 1. This is when we're most efficient and effective, but it's also when we're most prone to mistakes. We need to move to System 2 when it's new tasks that we're learning, when we need to learn how to problem solve. When something is not going as planned, we really need to move to that slow, thoughtful brain of System 2. And some of us do that better. We need to know when to put the brakes on. Let me give you a few examples. So I drove up here this morning from Knoxville. It wasn't an interstate like that, but it was pretty smooth driving. As I drove up here, I didn't have to brake for a whole lot. So, I was listening to the radio, thinking about what I was going to say with you. I was in system 1 thought process. I didn't think about putting how hard I needed to press on the gas pedal. Maybe I should have a little bit, but or if I needed to steer a little bit more, it was kind of automatic process. Not a lot of active thinking coming on. But I needed to be ready to move to that system 2, especially this time of year in East Tennessee, in case I saw one of those things and I didn't want to land in that pothole. I needed to be ready to put the brakes on. You guys look like you need waking up, so I'm going to get you to help me here for a second. Repeat after me. Silk, 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 silk. What do cows drink? Oh, you've repeated after me. You're supposed to answer the question, that too. What do cows drink? How many thought milk? They drink water. So I had you in that system 1 thought process and kind of this repetitive thought process. And so a lot of you said water. Some people do say that, repeat after me, and I always forget to give a caveat there. Other things. On a Saturday morning, you get up and instead of heading to the store, you start heading to work. Or how many have been driving down the interstate, lost in thought, and missed the exit that you were supposed to take? How many, as a clinician, and this is probably as we get older in our clinical practice, you do this more. When I'm listening to a heart, sometimes I go through the motions and I'm not really listening. I can't remember what I heard. Or I look at the patient's ears and I can't remember which side of the body was infected. If it was the right ear or the left ear. I'm in that kind of automatic mode, that system 1 mode, and I'm not really thinking about what I'm doing, and I need to be thinking about what I'm doing. I need to put the brakes on. But in medicine, like I said, system 1 is where we're the most effective and efficient. We really need to get to where, especially if you're practicing in a high-paced environment like the emergency room, where your skills are acquired and your knowledge is such that you can practice in that system 1 critical thinking mode. And you do that by gaining knowledge. Think about the very first time you went in and did a history and physical. That felt really weird, didn't it? You probably had your notes there to tell you what questions to ask, to make sure you got everything. Everything was very deliberate. It probably took you 2 hours to do your first history, and the problem was just ear pain. But as you go on, you get more comfortable with it. And you learn what questions you need to ask and how to focus your history and physical exam. So you've got the knowledge, you've got all the book knowledge on how to do that history and physical, but then you're gaining the clinical experience that will help you do a focus history and physical. And then kind of that next step, when you're working in a fast-paced environment, you learn how to recognize patterns of diseases. So you can quickly come to that diagnosis. How many of you have been staring at these blocks and trying to figure it out? Okay. So if I ask you now what the answer was for that white block, it might take you about 3 to 5 minutes to figure it out. So anyone want to vote for A? Anybody want to vote for B? C? D? Well, the answer is A, and so those that voted for A are really fast at figuring out a pattern recognition. But if I came back to this slide at the end of my talk or the next day, you would have a memory of what that pattern looked like, and you would get it much quicker. And the same way as we develop pattern recognition in our clinical diagnostic abilities, you begin to recognize. So I see a triage assessment that's a 3-year-old with elbow pain. I'm thinking nursemaid's elbow. We know that pattern of kind of the things we look for with that history. But it's when we're thinking like that, in that system 1, we have to be aware of our biases. Because not every 3-year-old with elbow pain has nursemaid's elbow. And you have to be able to recognize when I need to pull out and be more thoughtful with that diagnostic process. So you're kind of thinking, so how do we ever get it right? Our biases can work for us and against us. Most of the time they are good and they help us in that system 1 thought process is, but sometimes they can be pretty ugly and lead us down a path that we don't want to go. When you start studying cognitive science, there are hundreds of different biases that they describe. As we've looked at this in medicine, they've kind of pared down the number. And on one of your handouts, I've listed a page of biases that really are more applicable to us as medical practitioners there. And I'm just going to highlight a few of those, but this is your reference to kind of read and learn more about it and to think about it. Because the first step is becoming aware of these in our thought process. They're really divided in three categories. The first ones are heuristic failures, and those are failures in the way we think. Anchoring. The physicians and the care team that were caring for Alyssa were anchoring on anxiety. That was a diagnosis they had given her, and they were not moving away from that diagnosis. So you can see why her mother is passionate about thinking and learning and teaching about the way we think, because she really felt like that they had anchored on a diagnosis that wasn't relevant. Confirmation bias. I'm going to move away from healthcare just a little bit. I have 4 boys. When one of them was in college, I get a phone call from him one morning. He said, "Mom, I've had a wreck. I'm okay, my car's not bad, the other driver's okay." So then I can relax and I can say the next question, what happened? So he was getting up morning, going to class, a road that he has driven 100,000 times. So very kind of much system 1 thought processes. Probably a little sleepy too at the time, it was a morning class. He got to a stoplight. There was a car in front of him. He was focused on that one piece of information, the car in front of them, and what is that car doing? The car in front of him went. So he followed the car in front of him. Unfortunately, the car in front of him turned right. He didn't look up at that stoplight and see it was still red. He missed an important piece of information because he was so focused on one piece of information, he ignored the piece of information that could have prevented him from having a wreck. That's confirmation bias. Sometimes we're so intent on proving what we think it is, we miss something that tells us it's not that. Yin yang out. Have you ever heard the terminology, he's been worked up to the yin yang? So you get a patient like that, you think there's absolutely nothing else I need to offer that patient or that I could potentially do. What you need to kind of circle back around on is that history and physical exam, because the clue is probably there and everybody else has missed it. Premature closure. That's when you accept the first diagnosis that comes to your mind and go with it from there. There are errors of attributions, and these are errors that are really the characteristics of yourself or the patient that you're seeing. Affective bias. Some patients affect us differently. You have that gut, I don't really like this patient, I don't really like this parent. You have to keep that in check. Can you guys think in the ER what type of patient might affect you in that way? Frequent flyers, absolutely. Those are probably the most common patient to affect you that way. But they can come in and have a heart attack, a real heart attack. So you have to be wary of kind of your gut reaction to a patient and to their family. Appeal to authority. I think we have medical students and residents in the room. Are you afraid to challenge your attendings with a diagnostic dilemma there, that you think that it's something else and they're going down one path? You don't need to be afraid. You need to speak up, and it really needs to be a team effort with that diagnostic process. Attribution. Sometimes, like the adolescent female, you think every complaint is made up because you think adolescent females are all crazy. There. Errors of context. So if you make a difficult diagnosis, say you've had an adolescent female come in and you've diagnosed lupus on that patient. for the next multiple times when any adolescent female that comes in and has some of those characteristics, you're going to think they have lupus. The same token, in flu season, you think everybody has flu. You're going to latch on to the diagnosis you made last. Framing effect. This is important when we think about how we communicate with each other. And it starts with triage. You may frame a patient in a certain way. This is a crazy family. Or as you hand off to the hospitalist, I think this is what it is, they're crazy or whatever, So you really have to be careful, and you have to be careful on those handoffs and transitions of care that you don't frame a patient, because that's an opportunity for someone to have a fresh look at the patient and really maybe have different insight. Zebra retreat. So we are taught that it's not the zebra, that it is a common diagnosis. Does anyone know what that medical dictum is called? Y'all don't remember that? Occam's razor? The law of parsimony? That the simplest answer is the correct one? That a patient can't have two diagnoses? But sometimes two different diagnoses can apply. Sometimes it really is a zebra. And sometimes if you hear hoofbeats, it's not horses, it's a zebra. And you really have to kind of get rid of that if things don't fit. And that's something called debiasing. So how do we get better? You would think, this is a complicated process. Can we get better with this? The Institute of Medicine, in their book, really has divided the process to think about getting better in 8 categories. Some of these are high-level medical systems, government-type policy, or political advocacy type things that they want to do. But when we get down to the individual, we really want to think, and to the individual organization, we really want to think about teamwork, education, and this is one of those, I hope, one of those potential opportunities to educate on the pitfalls. And then we have to develop a culture from learning from our diagnostic era. So what we did, and what I'm going to take you through, is what we call a cognitive autopsy. This is our first step, and it's really focused on education. We all have case conferences and M&M conferences when we really focus on the disease-specific nuances and what we're learning from that disease process. What a cognitive autopsy, we do that, but we also focus on how we were thinking as we chose the steps in the diagnostic process. So we choose cases to present where potentially you could see where a bias influenced the wrong direction in care. And then we talk about it, and we talk about how we could have done that differently or process to improvement there. So I'm going to take you through a case, and this is modeled after a case that we actually presented, but the names have been changed to protect the innocent and to protect PHI. And I want some audience interaction with this. So we have a neonate that's transferred to your institution from Hospital A. A day prior to that admission, the patient had a history of a low-grade temp. They went to Hospital A on the day of admission. The temperature was 101. Was brought in by the grandmother. This is about a 3-week-old baby. Was brought in by the grandmother. The grandmother was concerned for rapid breathing and popping sounds. The patient had congestion for a couple of days. Additional symptoms were vomiting and fussiness. Also had this history of some weird lesions on the nose. The grandmother didn't know exactly what the patient was being treated with, but had been treated for about 10 days for these weird lesions on the nose. They thought it might be impetigo. Hospital A performs a sepsis workup, which was negative. They also did the CT of the head. It was negative except for elevated transaminases. They did a CT of the head that was normal, as well as a chest x-ray. So you're receiving that phone call from Hospital A as the physician, as the medical control physician. What advice do you want to give the hospital? So how many would vote for A? B, C. I'm saying row 7 because that's all they had. D. All right, so that's the advice that was given to that hospital. Do D and send. So when the patient arrives at your facility, additional information is obtained. The facial rash was treated with an antibiotic paste. The patient was also having some diarrhea. This is a 37-week NAS or neonatal abstinence syndrome patient. In triage, while the nurses are with the patient was noted to DSAT in the mid-80s. They thought the patient might have had some apnea. They sent the CT scan with the patient, but they didn't send the chest x-ray. Your physical exam is pretty unremarkable by the time you're examining the patient, except for what you thought was truly an impetigo rash. So what do you do next? Any additional tests that you would want in the emergency department? Someone be brave. What?
Chest x-ray.
You want to repeat the chest x-ray. Anything else?
This is a 3-week-old, you said?
3-week-old.
So maybe a spinal tap?
They did that in the other hospital. It was normal. So what's your diagnosis?
Vital illness.
What?
Vital illness, possibly.
Possible viral illness. Do you admit the patient?
Yes.
Do you admit the patient to the floor or to the ICU? No one's going to...
Floor, based on what you have.
Floor. So what they did, they didn't order any additional test. They trusted that the chest x-ray was normal at the outside facility. They just watched for a couple hours in the emergency department to make sure that apnea wasn't going to recur. Didn't really have an explanation for what was seen there. And they admitted the patient to the floor. Patient gets to the floor, and an astute nurse goes in and does their own history and physical exam. And when they're taking that history and physical exam, they're actually, they are hearing a popping sound. The baby is breathing kind of hard and irregular, and they're hearing this popping sound. And the grandmother says, yeah, that's what I've been hearing. I've been telling doctors that, and nobody seems to think anything of that. So that nurse caused the admitting physician to go in the room and look at the baby with her. The attending at that point in time hears the same thing, is concerned about the baby's respiratory status. So they ordered the chest x-ray, and they also order a skeletal survey. And what they find is multiple rib fractures and a clavicular fracture. So this baby was admitted as a possible sepsis, routine neonatal admission. And this was ignored initially. Forensics and social work ophthalmology consults were obtained. We didn't continue the acyclovir. All cultures were negative, and the antibiotics were discontinued at 48 hours. They felt the fever was secondary to atelectasis and small pleural fluid from the rib fractures. Opto exam was normal. The fussiness resolved with pain control. DCS was consulted, and the patient was sent home in foster care. We could have discharged this baby into an unsafe environment if an astute nurse hadn't done their own history and physical exam and paid attention to the grandmother's concerns. So when you think about that, where were the biases in our thought processes? Can you think, looking at that list, what some of the biases that, that might have been there? Look at my time here.
It was an expertise bias, because we thought the baby had been worked up.
So search status line had had a full workup. We trusted what they were doing. So we called off the search to kind of investigate anything else. Premature closure. That episode of apnea wasn't fully explained by anything that came with the baby, I think. I think they anchored, this is a routine rule-out sepsis, and really didn't expand their differential. And then potentially they weren't listening to the grandmother because they didn't perceive her as a valid historian there. So opportunities for learning from this case, but fortunately for this baby, was sent home in a safe environment. So we do this once a quarter and really try to think about how we think about patients. So what else can we do? What are other cognitive bias mitigation strategies? And it's not you just aren't thinking critically enough. We have to recognize that bias is important. We have to begin to learn from it. We have to identify it, and we have to teach you the strategies to get better. So this is from the Institute of Medicine, and it's a checklist. So when you're doing a history and physical and really thinking about a diagnosis, ask yourself these questions. We've put this checklist in our ER and in our inpatient floors to really remind us as we're kind of thinking through that differential diagnosis. You have to know when you're most at risk. When you're managing too many things at once, trying to think about too much. When you're sleep deprived. When your mood is negative, and potentially if you're impaired. I don't know what that is. You have to recognize diagnostic uncertainty. You have to think, did I accept the first diagnosis that came to mind? Am I being influenced by bias? And these are some of the biases that you might want to think about that you're being influenced by. So there's some internal forcing functions that you can do. We have to recognize that the differential diagnosis is very important, and I'll talk about that more in just a second. But we also have a lot of standing rules or forcing strategies in medicine. What is the worst case scenario for this patient, and you want to make sure that you rule that out. I think we've always been taught if you think about doing a lumbar puncture, do the lumbar puncture, because you don't want to miss meningitis. You don't want to miss sepsis. You don't want to miss Kawasaki's disease. You don't want to miss when that patient presents with the infant presents with bilious emesis. You don't want to miss the small bowel obstruction. So we have to know those diagnoses that we can't miss to make sure that we're thinking about those every time when a patient presents. The power of the differential diagnosis, it establishes a framework for other considerations. As you begin your medical career, make it a habit to always come up with at least 3 different diagnoses that this could be. I think as we get further along in our medical career, we still should be doing that, but sometimes we're not as intentional about doing that as we need to be. Because that can lead to a more timely, definitive diagnosis. It helps communicate diagnostic uncertainty. We also need not to be afraid to say, I don't know. Just list the symptoms that they have, and I don't know how I'm going to put all this together. It needs to be both verbal and it needs to be written. That keeps us all accountable for our thought processes. I have forgotten more than I know right now. So I'm a firm believer that I need to have resources at my fingertips to help me make that differential diagnosis. We have easy access to UpToDate. Isabel is a tool that actually you can put in the symptoms and it generates that diagnostic differential for you, something to investigate, to really have at the fingertips for your doctors. And if all else fails, stop and think is not a bad thing to do. And these are the high-risk situations when you should take a diagnostic timeout. If you're trying to make that square peg fit in the round hole and it doesn't work, you need to slow down, go to that system 2 thought processes, and take that diagnostic timeout and use this kind of checklist to work through the process. Team engagement. This is something we don't think about a lot in diagnostic safety or in diagnosis, but several of the academic institutions across the country, with their resident teams especially, and when you do that handoff, they do a really formal process of, I'm going to poke holes in your diagnosis. So you present it to one team and they kind of back at you to see, really are we on the right track? But that really helps improve that team engagement and that diagnostic process. And then empowering every person on your team, nurses, anyone that's seeing the patient, to take that diagnostic time out and say, I don't think this fits. And we have to be aware of especially buried information in our electronic health record, especially pending lab results. Somebody needs to own that because that can be missed and you miss that key diagnostic clue. Then we think about system improvements, and I think the hardest thing is identifying diagnostic error. We all think that hindsight is 20/20, and I can tell you the diagnosis was missed, but we don't want to own that there was a potential opportunity for me to make that diagnosis earlier. And I think that's the first step in improving, is saying, yeah, the information was there, and I could have made that diagnosis, for accountability and for continued learning. And we have to create a culture where it's safe to do that, and it's safe to learn from that. And it's hard. It's hard when I am looking at events and I want to classify them as a safety event or not. When our critical thinking is involved, it's really hard to say that because it doesn't feel good. But it really is our opportunity for improvement. So we have to create that culture. Maximize support through EHR with our care maps that we're doing, and these are our evidence-based guidelines for the entire care team. And they're accessible in real time through our EHR. Like with CROUP, we create those kind of stop signs or those stop points that if this is happening, you need to consider alternative diagnosis. Like if that patient is not responding to racemic epinephrine, I need to think about something else. But that kind of gives it spelled out in our care map so every member of the care team can see that and raise that red flag or concern. And then finally, really the last thing and the last frontier in this, and it's something that Carol Himmelgard is passionate about, is we need to learn how to engage our families better in the diagnostic process. This other handout that I gave you came from the Improved Diagnosis website. And it is kind of like our Speak Up campaign if you are engaging your families into helping you make sure you do the right CLABSI care or the right urinary catheter care. This is the same kind of a checklist on how you teach families to make sure they're giving you the right information and that they're allowed to engage in the process moving forward. We haven't done anything with this yet, but I think it's a really good tool. I presented this to our Family Advisory Council to kind of get their input on how we could engage them in the diagnostic process and what our families would feel like. And they thought it was, we were on the right track. Again, we have to kind of implement it. But one of the mothers talked about, she had come from another state with an outside subspecialist that was seeing her child, used open notes. That's really hard for us to think about doing. But she said it was really powerful in making sure that he had the history right and that she understood. So she was involved in creating that history or that subjective evaluation with that note in real time. And he would review it her. This is what I wrote down. Are you sure this is correct? Would do his history, his physical exam, and then write his assessment and plan. And she would be able to look at that with him, have access to that through her patient portal, so she was continually reminded. That's a level of transparency that takes, I think, very brave organizations to go there. But she felt like it was a very powerful tool. So something to think about. Gone are the days of Marcus Welby, and how many in this room know who Marcus Welby is? I'm sorry. So I don't know who to think about in modern day TV doctors. I don't think there is a Marcus Welby.
I refer to him all the time, and I just get blank looks.
Okay. Well, Marcus Welby was the doctor that everybody trusted. You would have him in for dinner. I mean, he could do no wrong. And he was a master at making diagnoses, and everybody absolutely trusted him. I think you can say that we've probably tilted the pendulum a little farther to the right side, where we have a lot of mistrust and non-compliance with what we tell patients to do. We have to move to really a balance where there is that deference to expertise. We are healthcare professionals. We really do know a lot more than the family, but being preoccupied with failure and engaging that entire care team, including the patient and family, in the diagnostic process. And in that way, we can improve our diagnostic safety. So I want each of you in here to make a commitment to take each day and think about how you're thinking and improving your diagnostic safety. We recently did a grand rounds where we presented a diagnostic unknown to a physician who then took us to the process of creating that differential diagnosis and making the diagnosis, and along the way talked about some of the pitfalls in that diagnostic process. Our CEO was there, and he watched the whole thing kind of unfold, and we got an email from him after that. And he said he had renewed respect. He always respected what we did as clinicians, but had renewed respect of that process and recognizing how complex it is and what we do every day to heal our patients was incredible. And I think each of us needs to own that and needs to be committed to that. And in the words of Pat Summitt, it is a day-to-day task. Left foot, right foot, breathe, repeat. And why do we need to do that? Keeping with the sports analogies, I'm a big Boston Red Sox fan. This is the first game of the 2013 World Series. They're playing St. Louis, first inning. They're up to bat, Boston is up to bat, hits a routine infield pop fly. St. Louis has one of the best catchers in the major league at that point in time. The catcher's running towards the pitcher, waving his hands, waving him off. The pitcher's saying, I got it. They're not listening to each other, not communicating well. The ball drops in the middle. For us, as we think about what we do every day and how we treat patients, we can't afford to drop the ball because the patient is that ball. So questions, other thoughts, things that you want to learn more about? Did this resonate with you?
How long have you been doing your cognitive autopsy?
We've been doing it for 2 years. Yeah, every quarter, once a quarter for 2 years.
And who attends that?
So it's open to anybody, so we have a mixture of both of medical staff. We put one in the morning so the surgeons will attend, or we intentionally choose a case that's a surgery case to get the surgeons to attend. So it's usually about half medical staff and half nurses, respiratory therapists, or pharmacists. So it's really the clinical staff that get the most meaning out of that cognitive autopsy.
I might be interested in hearing your thoughts. We have a duality here, right? On the one hand, we're saying that improvement in safety can be had by medical pathways that ensure consistency of treatment of the disease process. But then on the other hand, we have this cognitive bias. And so I find it intriguing that cognitive bias seems to feed into this process. I want to make everything
Fit.
so I can follow the pathway, and maybe not. It's got to be a balance between those two things. And how do you balance that?
So I think we have to continue to preach that bias is a concern and that pathways don't fit every patient. And you have to have the disclaimers read and clear that you are the clinician and you can deviate from this pathway. Now give your reasons so you can keep the team engaged. And then one thing that we have done is to put kind of stop signs along our pathways to say, if this is not happening, you need to consider something else, and what that something else might be. I think that's helpful in kind of real time, because we also recognize it's hard to retain all the knowledge that you need to retain for day-to-day work there. But it is, and it's just, I think we have to continually raise the awareness that we are not robots, that we have to master that art, and we can't lose that art. That's the value that we bring to medicine, is our history and physical taking and making and doing skills that make us different than Watson on IBM there, that make it so that he will never be able to do what we do. A computer won't be able to do what we do.
Thank you for a wonderful talk. And it seems like in this day and age, when we have so many distractions, if you will, there's everything's on a medical record, but then it's not everything, and there's distractors to that, and then there's distractions to those distractions. How how do you view that? I mean, when it's so important to be off the moment, like you said, you kind of can, by automaton, go do some things that you're doing all the time and lose the moment, if you will.
Yeah, I think we have to be very cognizant of taking those pauses. And I think as we have created a monster in our EHRs, and I think we need to step back from that and really think about that in the continuum of diagnostic safety and do a hard look at that whole process, I think. But for the quick moment, it's really is stepping back. What do I need to know, and where is it, and how do I communicate that effectively? I know it's really hard for me sometimes to look at a note that has been carried forward day after day after day and doesn't contain the information that I need to know about that patient. So we're just starting the process of giving feedback to practitioners when we see that type of a note in the chart that contains so much inaccuracy. But that's, we had the paper where you couldn't read it, and now you can read it, but it doesn't mean anything. That we need to really make that conscious effort of making our notes and our documentations meaningful. And how do you do that in the time pressure of everything that you're doing? And that's just an ongoing process for improvement there. Yeah. I think they're great because I can see everybody's thoughts, and I can have access to a lot of things I didn't, but we just have to make sure it's readily accessible. But any other thoughts? Questions? Okay. Thank you, guys.
Thank you.